So guys, if you're just joining in, we have Dr. Haroon with us. He'll be giving us a hot update on COVID-19, hopefully the last one. Please do share with us where you're coming from and what you're expecting from this webinar. We're expecting a lot of questions today. Dr. Haroon, I hope that you had your coffee.
Yeah, absolutely. I would like this to be more of a discussion than that acting. So I've got a few slides just to set the topic in motion, and then we'll take questions or we can discuss whatever you feel like. And the field has moved forward quite a bit, and I'm sure there'll be a number of questions.
Yes, absolutely. All right, thank you so much. We're so grateful for having you here. We're very lucky to have you here. Thank you so much for accepting the invitation.
Oh, such a pleasure, and thank you for the opportunity.
All right, so let's get this started. So good evening, everybody. Welcome. My name is Eli Karam. I'm a medical resident. I'm also a AS warrior and a board director at the CSA. So first of all, let me thank our partners for the opportunity we always thank our partners because they actually are supporting us and giving us this opportunity to present an event like this tonight. So let me start with a brief overview of the CSA. We'll then have the presentation of Dr. Haroon, and we'll leave a big part of tonight for the Q&A. So if you have any questions, please drop them in the Q&A box. So let me start with a brief introduction of the CSA. So who are we? The CSA is a national association with the sole purpose to support those diagnosed with spondyloarthritic diseases. We are a federally registered not-for-profit corporation. Our board is comprised of volunteers living with or affected by SPA. We have an executive director and a social media expert that we thank so much for everything that they're doing and the amazing job that they're doing. So what's the mission of the CSA? The mission of the CSA is to be the leading voice for the spondyloarthritis community in Canada, providing support, education, advocacy, and awareness for patients, caregivers, loved ones, and healthcare professionals through innovation. We have 4 strategic pillars: education, advocacy, awareness, and support. We try to bring awareness through social media, community support, information sessions, webinars, and international awareness and community activities. We try to advocate for patients, we try to shape policies, get better access to medications, devices, services, and we do support research, because we truly believe that research is key to have a big impact on patients. We currently are trying to support patients through virtual group meetings, peer-to-peer support, telephone support, email support, Facebook groups, and recently coaching. Let me give you a brief overview of what coaching is and what coaching can provide you in order to live better with AS. So it all started, let me give you a small story. So for me, it all started when I felt as a patient that a key player was missing in the multidisciplinary team that was taking care of me. When I started working with a coach, it really improved and accelerated my healing process. And this is why I trained to become a health coach myself, in addition to my medical background. So what is coaching? Well, coaching is not therapy. Coaching, so if you're experiencing anxiety, depressive symptoms that are heavily impacting your quality of life, coaching is not the right solution for you. Coaching is about having that partner, that ally that is going to support you during difficult times, probably better than your own family and friends, because he simply understands you better. Understand that you are not faking being sick, but you are, however, faking being well. He will understand that at times you just need to rest. and he'll encourage you to do so. He'll be your sort of an accountability partner to make sure that you're keeping your balance and respecting your bandwidth. Working with a coach is about providing you with that safe, non-judgmental space to create new mindsets. Yes, living with AS is hard, and learning to live better with AS is hard too. So let's choose the heart that will serve us better. So the coach will use active listening, challenging questions to get you to think differently, take action. He will help you accept your new reality and update your old belief system. He will use the power of self-compassion to help you create your updated you. So the coach will help you also manage your pain better and increase your emotional agility, because as we all know, emotions play a key role in pain control. So it's really about that 10%, that marginal change that's going to have a big impact in your life. So the CSA is proud to partner with Mobius Coaching and Management. We are offering you 2 free sessions. All you have to do is go to spondylitis.ca/coaching and choose a coach that you feel best suits your needs. We have a lot of interesting upcoming events coming up and a website that is being rebuilt with new content and tools, easier navigation and functionality. And just in case you're not a member yet, please do feel free to join us. Just go to spondylitis.ca. Our membership is totally free. We try, just a quick note, the information provided here is not medical advice. So always discuss medical treatments with your own healthcare provider who knows your medical history. So that being said, I'll leave the mic to Dr. Haroon. Dr. Haroon is the co-director of the spondylitis program at UHN in Toronto. He's the associate professor of medicine and rheumatology, and is the VP of the Canadian Rheumatology Association. He's a clinical scientist, and he did a doctorate of medicine in clinical immunology. He did a doctorate in clinical immunology, and he studied functional genomics and AS pathogenesis. We're very lucky to have him here talk to us today about an update on COVID. Thank you so much, Dr. Haroon, for being here.
Thank you very much, Eli. It's always a pleasure to come to a program at CSA where you connect with your patients, and it always gives me great pleasure. So we did. I can't remember the last date we did a COVID vaccines webinar, but it's not long ago. But a lot has changed for sure. I think you can see my slides now, right? So yes. these are just randomly put together slides based on what I thought might be of interest. I see that a few questions have already come in. We can plan for if there is a related question to what we are discussing. If you want to stop me at that point, that is fine, and then we can discuss that at that particular point, which may be more interesting. Or if you feel that we should just go through the slides. I think I have around 15 or 20 slides, and then we can discuss after. So again, thank you again for this opportunity. Now I'll talk a little bit on the recent updates. I'll start with the disclosures. Okay, so currently we have 4 vaccines approved in Canada, of which the Pfizer got a recent approval also for the 12 to 15 years pediatric age group use. Previously, Pfizer was approved from 16 years and up, and Moderna, because most of the studies were done in individuals who were 18 years and older, their approval was for those individuals 18 years and up. AstraZeneca and Janssen are also currently approved for use in Canada. Looking at the vaccination status, let's first look at Ontario. You'll see here 57.4% of the total population, which is roughly, if you look at the adult population, around 71% have received at least one shot, which is which is good. We're getting there slowly. And if you look at fully vaccinated, however, this is a very, very small number here, okay? So around 6.2% of the adult population only have been fully vaccinated. So definitely we need some work to do there. And that is, the success in the first dose is primarily from the change in policy that we took a few months ago, where priority was given to getting at least partial immune response and partial protection after the first dose, and delaying going off label on the second dose of vaccine. This is where we are at, for the vaccines distributed and the vaccines administered. You can see, most of the provinces here are doing quite well when it comes to the vaccines that are distributed versus administered. So initially, there was a lag between the available number of vaccine doses and the doses administered because of issues with scheduling and things like that, but we have caught up on it, and there is significant community involvement and pop-up clinics and everything that has helped us improve. There's also a lot less restriction and looser rules, and there's more emphasis on more people getting vaccinated than on really strictly regulating who gets vaccinated. So if there is any free vaccine dose available, immediately people are called in so that we don't waste any doses. And with that policy, the daily doses administered in Canada has definitely gone up. There are fluctuations based on availability and local issues, but in general, the trend looks really good here. Okay, a few slides on the Canadian Rheumatology Association position statement. We have gone through the original statement in the last webinar, so I'll just talk about what is new here. And I'll end this section. I think I'll end with one slide from the American College of Rheumatology guidelines, because they've got a detailed table on what to do with medications related to vaccination. So first of all, CRA is supportive of Health Canada prioritizations and local regulations, whatever they are. We definitely agree with sticking with the Health Canada prioritization and the local regulations and policies on vaccine administration. Having said that, it should be emphasized that patients with autoimmune diseases, and if you remember the early days, those who had autoimmune diseases were sent back from the vaccine centers because they were considered to be not eligible for, and a lot has changed from then. And CRA was very strong initially itself in advocating that patients with autoimmune rheumatic diseases or connective tissue diseases should not be discriminated against. So they should be, in fact, prioritized for vaccination. There are still some unknowns. For example, there is it's really not completely known if the vaccine response may be lower in individuals who have active disease. Obviously, for any vaccination, it is recommended that individuals be have a well-controlled disease before getting a vaccine. But given the circumstances around COVID-19, the recommendation from the American College of Rheumatology is that unless a patient has got critical disease that requires intensive care, you should get the vaccine even if the disease is active, because protection is extremely important considering the severe consequences of COVID. Okay, and because of this unknown potential around vaccine response in autoimmune rheumatic diseases, even though you're completely vaccinated, you should continue to follow the public health guidelines. This is specifically for rheumatic disease patients, because we cannot be 100% sure, and routine testing of neutralizing antibody titers and cell-mediated immunity are not regularly available for us, and it's not recommended also. So it's better to be safe. Yeah, Ella, you had a question?
Yeah, so in accordance to what you're just talking about, we're having questions about the efficacy of the vaccine when you're taking the medication and prednisone.
Right. So I think 2 slides down, we have a table on that. We will discuss about the medications there. And having said that, CRA does not recommend a specific vaccine. All the 4 vaccines available, whichever is available locally, should be taken. And as I mentioned, what the level of disease activity is, it should not be a barrier for vaccination. At whatever state you are in, it's best to get the vaccine as early as possible. Okay, now, again, as I mentioned, local practices and Health Canada prioritization may be different, but we do recognize that COVID-19 vaccine responses may be slightly lower for those individuals who are immunosuppressed, and so they should be prioritized for keeping them at the regular interval for vaccination rather than following the increased gap that is currently being practiced. Now, when I have talked about this before, immunologists and other individuals who see the bigger picture have come back and said that yes, that is all right, that is an appropriate recommendation, but however, we should again consider how the COVID is spreading within the community. We have to weigh the pros and cons of prioritizing a group to get both shots versus getting first dose to the maximum number, which in turn will protect everybody, including those with rheumatic diseases. So that's again something to be weighed. But the CRA recommendation in the statement is that, if possible, there should not be an increased gap. And currently we know that those who are on immunosuppression are being allowed to come in for earlier second dose vaccine, and we are providing letters from our clinic, and I know that many other rheumatologists are also doing the same in support. Okay, this is a table that I was referring to, and if you look specifically at the different medications in this table, and here is the timing consideration. So I will say that this is from the American College of Rheumatology. From a Canadian Rheumatology Association perspective, there are 2 main things that stand out. One thing is if you're on methotrexate, okay? So you can just forget this table for now. Just consider the medications you're on. If you're on methotrexate, then a gap of at least a week is recommended after getting the vaccine, okay? Because there is some data out of the flu vaccine trials previously that the antibody responses are lower in those who are taking methotrexate. So the recommendation is that you wait at least a week, so you give the vaccine a chance to develop some immune response. The second one is around rituximab. Now, rituximab is a strong monoclonal antibody that really suppresses the B cells. And as we all know, B cells are a strong component, an important component for developing humoral immune response or antibody response. So recently I saw a study that looked at the timing of vaccines after a dose of rituximab. And if you look at the graph, you almost don't have any antibody response till almost 6 months after the rituximab dose, okay? So obviously, if somebody has just recently got rituximab infusion, and if the community transmission is really high, I would say go ahead and get the vaccine, maybe give a gap of at least 2 months so that you have some amount of immune response there. The reason why I say that is, one, we don't know whether it is only the antibody response that is going to protect the individual. So there is good correlation between humoral and T cell response. So if you have a good humoral immune response, you also have a good T cell response. So the vice versa, if you have a good T cell response, you have a good immune response. So there definitely is a correlation between the two. But however, if the community level of transmission is really high, you at least get some partial protection. So down the line, there may be recommendations for these individuals where they may get additional booster doses once the rituximab effect goes down. So that's down the line. So things may change down the line. But for now, I would say, if possible, give a gap of around 1 to 2 months, get the dose if the community level of transmission is really high. If you're really well protected, then you will see that the longer you wait, the higher the chance of getting the antibody response. So here you can see here, rituximab, the ACR recommendation down here is schedule the vaccination so that the vaccine is initially approximately 4 weeks prior to the next schedule. So, so you give 4 weeks of time if you are right before the rituximab infusion. That is the recommendation. But what I said is, if they have already received the rituximab infusion, then the delay is around 2 to 4 weeks after the final vaccine dose. Okay, so if we talked about methotrexate, we talked about rituximab. These two are the main things that are referred to in the Canadian Rheumatology Association. But here in the ACR recommendations, there are a few other medications that have been, and JAK inhibitors. These are not yet commonly used because it's not a license for axial spondyloarthritis, which is the current call, for ankylosing spondylitis. But this is commonly used now for rheumatoid arthritis patients. It's also used for psoriasis patients as well, psoriatic arthritis patients as well. So those, according to the ACR recommendation, again, similar to methotrexate, you hold the JAK inhibitors. And for JAK inhibitors specifically, they were recommended 1 week after the vaccine dose. So that's what's recommended. Now, the other medication is abatacept. Okay, so abatacept is again primarily used for rheumatoid arthritis. Some psoriatic arthritis patients may also receive abatacept. It's not used that commonly for spondylitis. It's not at all used for spondylitis patients. Abatacept again works against the T cells. So for abatacept as well, there is a recommendation to hold the vaccination for a period of time here. There was a question around steroids, prednisone, which came up before. So if you look at here, very low dose steroids are not an issue. Generally, we see some responses diminishing once you go about 10 milligrams and significant diminishing vaccine responses once you go about 20 milligrams per day. So the recommendation here is that if you're about 20, unless you are about 20 milligrams per day, no significant modifications need to be done. But if higher the dose of prednisone, there is a chance that your vaccine response may be lower. So apart from the methotrexate I mentioned, if you look at hydroxychloroquine, sulfasalazine, leflunomide, some of the medications which AS patients who have significant peripheral arthritis or those who have psoriasis may be taking, including leflunomide and sulfasalazine, you don't need to really make any significant modifications. Okay. Okay, so that's with, do you want to stop and discuss that before we move on to this? Yeah.
Yeah, it would be great. So do you think that these patients will eventually, I mean, that was a question, will eventually require a third boost?
I think that might be the case. And even for individuals who don't have a rheumatic disease and those who are not on immunosuppressants, we don't know what happens after 6 months, really, practically on the ground, right? There seems to be a slight decrease in the immune response over the period of time. Granted, we do have memory cells that can quickly kick in if we get exposure again, but we don't know exactly how much protection there is after a period of 6 months to a year. So vaccine companies are at least preparing for a scenario where booster doses may be required. Only time will tell. Now, if we start seeing, if we start seeing a scenario like influenza, where you get seasonal kickbacks of infection coming, we may have to take booster doses. And the other possibility is that maybe those who are immunosuppressed and those who had comorbidities didn't mount enough response, and the recommendation may be in future that they require a booster dose at X months after the second dose. So these are still open questions. I don't think we have a definitive answer for that.
Perfect. And so we have a question here that how much vaccine protection would one get if taking 15 daily prednisone and Simva 200, especially that this patient is unable to taper prednisone for the vaccine. So what would you recommend in that case?
Yeah. What was the second? What, 200? 200, what was that?
Cimzia.
Oh, Cimzia. Okay, Cimzia. Yeah, so as far as TNF inhibitors are concerned, there is data to suggest that, especially in the inflammatory bowel disease population, those who are taking infliximab, there is some data to suggest that the antibody responses may be blunted a little bit. Now, for TNF inhibitors, in general, there is no strong recommendation to significantly alter the schedule. But if you're talking about a biologic that is given at a gap of 4 weeks, for example, or 6 weeks, you could, if you have the ability to time your vaccine, you could probably time it at mid-cycle. again, this is not based on proven data. It's just something which, what I feel might be a good, especially given the data just suggesting that there may be blunting of immune response. So you could time it mid-cycle. Now, if the biologics that you're taking is weekly, it's not going to be possible. If it's every 2 weeks, for example, adalimumab every 2 weeks, Cimzia can be taken every 2 weeks or every 4 weeks. So there is a possibility for adjustment in Cimzia. You could probably take it at a 4-week gap and time it at 2 weeks. So I would be a bit creative when it comes to that situation and time it in for the mid-cycle. Again, giving the best possible chance. Now, if this was a situation, this question was asked a year ago when you would just be called immediately for a vaccine, and that was the only way you can get the vaccine. If you lose that chance, then you have to come back 6 months later. I would say don't even bother thinking about anything. Just go get the shot. So right now you could schedule it. So now you have the possibility of doing that, and I would recommend that. Now the second part of the question regarding steroids. Steroids, for if you're on 15 milligram or 20 milligrams of steroid, you can understand that that's a fair dose of steroid. It's a good dose of steroid. It means that the patient really needs to be on that dose for controlling disease. I would not recommend playing with a dose of steroid just for the sake of getting the vaccine. I would say get the shot. Let's hope for the best response. Down the line, if there is more evidence to suggest that a booster dose is required, we can consider that at that time.
Excellent. Do you think that eventually we will have to measure the antibodies?
Specifically, the recommendation is you don't need to do that. There are kits available off the shelf and all that people sometimes take just for peace of mind to see a band forming. Oh, good, I got an antibody response. But we really don't know, what level of antibody response is going to protect you. Is antibody response alone enough? So I wouldn't recommend doing that unless there is a definite proof and protocol in place at a later time point. Even now, when you take your flu shots, you don't go and measure your immune response against flu shot, right? So just take it, and the proof is there that from the studies that you're protected. That's enough. Yeah.
Perfect. Thank you.
Shall we go on, or?
Yeah, we could go on.
Okay. So the other major thing coming up, which I'm sure you will all be discussing among yourselves, is this combination of different vaccines. So that's a very interesting scenario currently. I would think because of two reasons. One, of course, there were people who were worried about the adenovirus vector vaccines and the adverse effects. So a lot of individuals said, okay, I got my first shot. Can I take some other vaccine as my second shot? That's one scenario. The other scenario is that we don't have enough vaccines. So if you've taken any vaccine and you don't have enough supply of that vaccine at the time of the second dose, can you take any other vaccine available? That is what we do for most vaccinations. Like for flu shot, we don't exactly go for the same make and thing every year, right? So the flu, the variants change every year, and we get a new vaccine every year. So that is a standard practice. Now, specifically for the COVID vaccine, we at least have 2 studies currently, and many anecdotal evidences from different countries that are practicing this. So this particular study, the CombiVac study, this is a phase 2 open label RCT, randomized controlled clinical trial, and patients who were under 60 years of age were included in the study. They had received 1 dose of the adenovirus vaccine, between 8 and 12 weeks after the vaccine, they were, if they had no infection with the coronavirus, then they were randomized. So you can see here around 676 individuals who had received this adenovirus vaccine were randomized in a ratio of 2:1. So 2 individuals to 1 individual would receive the Pfizer-BioNTech vaccine, or they would just be followed as control. The idea is to see that would that single dose, compared to just not taking that not taking the second dose, would taking a different dose, with different vaccine, like specifically the Pfizer, mixing it, would that lead to good immune response? Would that lead to any unexpected side effects? So these are the two main things that are being tested. So let's straight away go. First of all, looking at the antibody response, we'll see that the antibody responses as expected in the two groups, because they had received, both groups had received the same vaccine, right? At around 8 to 12 weeks ago. So at baseline, their antibody titers are same. But 7 days after the Pfizer-BioNTech vaccine intervention group, the antibody titers have significantly increased. Okay, so it does work. So this is for the antibody titer, and this is a neutralizing antibody titer. So at 14 days, neutralizing antibodies were tested. So these are functional antibodies that are increasing after a switch in the type of vaccine. So it does work. How about vaccine safety? And in this, you can see that here the comparison is with control. So you don't really know in this particular study if continuing the same vaccine versus the other one, is it a different or not. But at least you see here, what you see here is that the majority of individuals had, within the first 7 days after vaccination, had just local and mild symptoms. No major adverse events were seen. So nothing life-threatening, nothing like that were seen. So you can see local side reactions you would expect with vaccines, whether you take the same or not. You can see myalgia, arthralgia, chills, headache, and malaise. These were all the adverse effects that were seen. But in the next study that I'm going to show you, it's a very good comparison if you take the same vaccine versus the other one. So that's the COMCO study. Again, this is a heterologous prime boost study, the COMCO study. And this was done in the UK. The previous study was done in Spain. Here, 4 prime boost combinations were tested. So you prime with the adenovirus and you boost with adenovirus. That's one combination. Adenovirus followed by Pfizer-BioNTech mRNA, second combination, and the reverse for, so that makes it 4 different combinations. And here, participants were 50 years and older. Okay, so unlike the previous study, this were for those who are 50 years and older. So this was this is from a preprint. This is available if you're interested. You can you can just do a Google search and you will land with this study. So I have this in a much more detailed way as an animation, but just to show you, if you look at the prime, so this part, the top half, sorry. Okay, the top half is for the adverse effects that you see after the prime dose, and the lower half is the adverse effects that you see with the boost dose after the second dose. Okay, and you will see that at the priming, there is not much of, if you look for the red color and the severe side effects and the hospitalizations, you don't see a lot of that after the first dose. Okay, maybe some fatigue, individuals had some fatigue a little bit, and other than that, not much. But with the boost dose, or the second dose, clearly the red color and the severe symptoms are higher. And if you look at specifically in which groups the severe symptoms are coming, again, keep in mind these are not life-threatening complications. It's just fatigue, malaise, fever, pain, chills, like that. Okay, and headache. If you look at, it's in this group and this group, and which are these two groups? These are individuals who received the adenovirus first, followed by the mRNA, or those who received the mRNA followed by the adenovirus. So what it shows is that, this is just a bit more in detail. What it essentially shows that mixing 2 vaccines may lead to a slightly increased local reaction and systemic reactions like fever, chills, fatigue, and such events. But again, there is nothing in the study that really prevents us from taking this approach, because there is no significant, at least in the first few days after the vaccines, we don't know about the long-term consequences yet, but at least in the first few days, there are no significant issues. Should we stop there? And do you want to take some questions there, or?
Well, there's no questions about that, but it's very interesting to see that, well, for now, there is no policy about mixing vaccines because we're still on schedule and we're still getting doses, right?
Yeah. Currently, there is nothing to suggest that we need to do this as a policy, but there might be many situations where this may be needed in the future. And at least these two studies show that it is doable. There is a good response, so no worries with that. And at least in the early phases, there is no significant life-threatening complications that one may expect. Because always there is a worry about mixing two different kinds of vaccines. You don't know whether the immune response you're going to get is going to be, causing any organ damage and things like that, right?
Yeah, absolutely. And in accordance to, in regards to time, so if we're getting a second vaccine that is different, so for example, with AstraZeneca, we're waiting 3 months, right?
Yeah, that's
so. What would you say about the time of the second dose?
Yeah. So the study was done was between 8 and 12 weeks, and generally for the second dosing, if you go by indication, you would probably be doing it around 6 to 8 weeks, right? And now we have extended it to 12 weeks and even beyond for some geographic locations. I would just follow the local regulations. Whenever you're supposed to get the second dose, and if there is a situation that you have to mix and boost, I would probably follow just the same timing. I don't think I will change that. Again, this is just my opinion. Yeah.
Oh, that's perfect. Thank you so much. You can continue.
Okay, so the other major thing that has been in the news a lot, and issues around messaging, and this has been a major issue. I still believe that yes, there is a signal, but the risk is extremely low to get blood clots with the adenovirus vectors. Now, just to put it in perspective, this is from the Thrombosis Canada website. You can see. If you start from below, consider if one gets COVID-19 infection, person didn't get vaccinated because they were worried about a thrombosis, and they get vaccinated, they get COVID infection, and they end up in the hospital. 14.7% chance of getting thrombosis. That's really high. And what's the average risk of getting thrombosis in an average Canadian or for those taking birth control pills? Is around 0.1%. That's a rough risk. But with this vaccine, it's 100th lower risk, right? It's just a 0.001%, 10 in a million of getting thrombosis. Now, the problem, however, is that this is for all forms of thrombosis, just like a deep vein thrombosis and things like that are all included here, which can be easily managed. Of course, as you know, it can be life-threatening if it goes into pulmonary embolism and issues like that. But the vast majority of people who are included here are mostly this local thrombosis and thrombophlebitis and DVTs and things like that. But the issue with the vaccine, post-vaccine thrombosis is that, first of all, it appears to be more of a systemic response, immune response, leading to low platelets and thrombosis in areas that potentially are life-threatening, and primarily, for example, central nervous system venous thrombosis, and also pulmonary embolism. So that is definitely a concern. But if you weigh it with the gravity of COVID vaccine, spreading in the community, I would think that the protection and benefits of vaccine far outweigh the risks. So I think most geographies would say that if that is the only vaccine available, and if the community level of transmission is high, definitely you should take the vaccine. Would be for most localities around the world, that should be, I think, the recommendation. Okay. So the other major issue is around variants that are kicking in, right? This has been a major issue in many countries, and you will see the the different variants that are, the nomenclature around the variants has changed quite significantly. But fortunately, at least from the early studies we have seen in the, this is a study out of Qatar, where where the predominant variants were the B117 variant and the B1.351 variant. And individuals who got vaccinated were well protected against these variants. You will see against the B117 variant, there was around 90% protection. Okay, and this is for the Pfizer vaccine, where you expect, where the expected protection is also around 90 to 92%, right? Against the B1.351 variant, the protection is around 75%. So there appears to be a drop of around 20% there against this particular variant, even for the Pfizer vaccine. However, against critical disease, fatal disease, the protection is really, really high at 97.4%. So we're protected against the serious illnesses, but against some variants, maybe the protection against milder disease may not be as high as against the original viruses that were, of the original variants of the virus that were there, or the wild type virus. Okay, the other study against for protection against these variants is from Israel, and you can see the predominant variant in Israel was the B117 variant. And look at, they started their vaccination program in December of 2020, and look how beautifully they have controlled disease with time, almost like it's back to normal there. And you can see here, this is the percentage of population that is fully vaccinated. It's very close to the percentage of population that has received the first dose, because they are prioritizing maximal vaccination as early as possible. And you can see here by March, where there's been significant dip in the cases, by March you will see almost 50% of the population had been completely vaccinated, fully vaccinated. So that shows the power of vaccines and the importance of getting vaccines as early as possible. Now, this is a slide which Eric Topol put together, and it's available on Twitter. It's a beautiful slide. Again, the naming of the variants has changed. You will hear more and more of these instead of the B117, which was the one more common in the UK. It's now called Alpha variant. You don't want to be associating infectious diseases with specific countries and populations. So that's the idea. And P1 variant, which is now called Gamma. Now, this is the one which is currently causing a lot of issues in South Asia. So the Delta variant, if you look here, there is an asterisk here. The transmissibility is the highest among the variants that we have seen with this. Very, very high level of transmission, easily spreads. Vaccine effectiveness there is a tick here. However, if you look at that asterisk here, where is it? Yes, if you look specifically here, the B1617.2 mRNA or AstraZeneca vaccine, after the first dose, the effectiveness is only 30%. So that's much lower. So the lesson really from this is that as time goes by and the longer we take to vaccinate individuals and the longer we are thinking that, okay, this will pass, let me not get vaccinated, I don't want to do it, the higher the chance that a mutant will come and that'll not, that none of our vaccines will be covering. So really the only way out of this is to vaccinate and vaccinate early, prevent all the possible different mutations that may arise in the future. Just get this pandemic out. So if you look at the Angus Reid Institute poll, there has been a significant confidence jump in the AstraZeneca vaccine. There were issues around the AstraZeneca vaccine. Johnson & Johnson still is not up there, but definitely there seems to be an improvement in the level of the comfort around the AstraZeneca vaccine. And among the provinces, Alberta seems to be the province with the highest vaccine hesitancy. So we have to really work around this and try to convey the message that, vaccinations are really our only way out. Fortunately, those who are willing to get vaccinated, almost 90 to 92% are willing to get vaccinated with the mRNA vaccines, and a good proportion are willing to get vaccinated with the other vaccines as well. So I think that is all I have. I'll stop sharing and then.
Well, that's a beautiful presentation. Straight to the point and just relating exactly what we wanted to talk about. So just to continue the discussion, especially in regards to mutants. So if you took the first dose and AstraZeneca as a first dose, would you take Pfizer as the second?
Yeah, as I showed before, whether you do it the other way around. Now, suppose you got Pfizer and suddenly, there is no supply, and if only AstraZeneca is available, I wouldn't mind doing the other way around as well. So as long as that is the local policy and that is approved, I don't have any issue around that. And as we already saw, at least in the early days, there is no significant risk of a major health issue with that kind of a combination.
And in terms of efficacy, would you say, especially that in terms of efficacy, in terms of immunosuppressions, in terms of mutant, do you think that patients with AS should benefit from Pfizer, for example?
I don't think so. I don't think we have to prioritize one vaccine over the other. Whatever is available, that my recommendation is if for example, you're in a specific locality where Pfizer is available, that's the main vaccine being administered, go get the Pfizer vaccine. Now, if AstraZeneca is available, go get the AstraZeneca vaccine. That is all available. There are issues around messaging. I know that during the NACI press conference and also NACI statement is that there seems to be a tiered approach to the vaccine. I would think take everything in context. If you're in New Zealand or if you're in Australia where there's hardly anybody around from where you can get COVID infection, obviously, you can make a choice and decide what is best. But if you're in a community where there is significant transmission going on, so everything is based on context, right? Significant transmission going on, and the goal is to get maximal vaccination doses per day. So I would just administer whatever is available at that particular time for taking vaccines. And if you look at the association recommendations, ACR and CRA, there is no specific prioritization of one vaccine over the other.
So folks, just go get your vaccines. In terms of side effects, would you say that migraines are possible side effects of the vaccines?
Which one? Sorry?
Migraines.
Migraine, yeah. So those who have a history of migraines seem to be getting flares of migraines. And those who don't have a history of migraines seem to be getting some headaches as well. Like I got a headache. I had to take a Tylenol after my shot. So, Mm-hmm.
And so would the side effect be lower after the second dose, or should we expect side effects to rise again during the second? And I know that there are a lot of people that are actually worried about getting even worse side effects after the second dose.
Yeah, well, anybody wants to try COVID? Or they want to try the side effect? So there are adverse effects for sure, like mild fever is possible, headaches are possible, joint pains are possible. These are the most common side effects, but compared to getting COVID, there's no comparison at all. So, and I also I've seen that the second dose, I can't say right percentages, but I would say probably 30% or patients with the second dose probably will get much more severe adverse events. I didn't get a significant. People were telling me don't book patients, don't book a clinic the day after your second dose. I didn't have any that level of symptoms. No. But I also know individuals who had who were couldn't really work for half a day because of fatigue and malaise and headaches. Yeah.
Yeah, we have the opposite question. So basically, if you have no reaction, does that mean that you're having no immune response?
No,
especially that you're on medications that kind of
I don't
immunomodulators.
I get it. It makes sense to think that way, but I don't think there is a correlation there.
You talked about medications that could decrease the efficacy of the vaccine. How about ibuprofen or other NSAIDs?
Yeah, I don't think that, you can imagine we are not recommending stopping a big gun like biologic. What is the level of impact that ibuprofen is going to make on your immune response? Like if I am having significant pain or joint pain and I need to take an NSAID, obviously if you want to start with paracetamol, obviously, which doesn't have anti-inflammatory effect. It'll help with headaches, it'll help with fever, it'll help with pain. And if it is not controlled with adequate dosing of Tylenol, then go for an NSAID, obviously. I don't think if you need an NSAID, don't worry about it. Take it. Yeah.
Perfect. And so palpitations, heart palpitations after vaccine, is it something that you heard about?
I have not heard about palpitations, but definitely it is possible, but I've not heard about that, no.
There's also questions about relating to allergic reactions to Humira. So if you're having an allergic reaction to Humira, does that in any way could tell you that you could have an allergic reaction to vaccines?
No, there is no correlation. The only situation where you should avoid it is if specifically you've had an allergic reaction, severe allergic reaction to the first dose of the vaccine that you're going to get. And even mild allergic reaction to the first dose of the vaccine is not a contraindication to get the second dose, because again, everything is in context. We are dealing with a mass pandemic now, and what you really need is protection. The risk that you take with that, is minimal compared to the significant risk of not getting vaccinated. So again, a history of allergy to food, history of allergy to local application agents, history of allergy to other medications. None of these are contraindications for getting the vaccine.
What should I tell my rheumatologist if I'm ready to take my second dose and I want my time to shorten my time? What should I tell him?
So I don't think your rheumatologist can make that decision. The only thing that your rheumatologist can do is, what you can do is, please give me a letter that states I have an autoimmune rheumatic disease. So if it's AS, no need to specifically say it's AS, just say it's autoimmune rheumatic disease. That's the language which somebody sitting at a vaccine center would understand. And if you're on an immunosuppressant, you can add that to the letter saying that you're on an immunosuppressant. A lot of vaccine centers, if they definitely have good supply of vaccine, will honor that. And if there is a local, in the local area where you are, if the direction is for those on immunosuppressants to get shorter vaccines, then you will get it. If you recall, then initially this shortening of the gap was only for those who had cancers, right? And who are on cancer treatment. But that has eased up a little bit. There's a little bit more leeway now. So if in your locality, if that is a policy that if you come with a letter, then you should be able to get the second dose. But I don't think your rheumatologist can make that decision. The only thing they can do is give you the letter.
So just to take, as a take-home message, everyone can and probably should take the vaccine, the only people probably that can take the vaccine is the people that are critically ill. And if just to summarize what you just said, is that basically we need to talk to our rheumatologist about stopping the medication, but in any ways, getting the vaccine is beneficial. It's just that we don't have enough data to see if it's going to be efficient on the long term.
Absolutely. So that's very well put, and that's really the gist of what I was trying to say.
No, that's perfect. Would you add something that you would like patients with AS to take home tonight?
What I have to say is that science is really progressed, and the vaccine field significantly had progressed by leaps and bounds with this pandemic, and I'm really impressed by the way people have come together in moving this field forward. There is a lot of evidence out there. Try to if you're not fully vaccinated, try to get that done as soon as possible. If you know individuals around who are hesitant to get vaccine, talk to them, give them your experience, tell them the importance, talk about this webinar, you talk about other evidence out there, talk about the context. The context is always important. This is not an easy situation. This is one of the biggest challenges that humanity has faced in our generation, and this pandemic is not any other ordinary infection. It had, if it was not for science, it really had the power to wipe out a large chunk of the population. And thanks to the progress from science and vaccine development, we are in a much better place today. So please, if you're not vaccinated yet, get the vaccine. If you know somebody who is not getting vaccinated, please try and impress upon them the importance of this. Yeah.
Well, thank you so much, Dr. Haroon. That was a great presentation, a great talk. I know everyone appreciated that talk. Hope we'll see you soon, but this time without COVID. All right, thank you so much, everyone. Have a great evening.
Thank you.
See you soon.
Bye-bye.
All right, thank you, Dr. Haroon.